All right. Welcome back, everybody. Welcome to the third session of the Immunisation Coalition's Adult Immunisation Forum. I'm Margit Anshin. I'm going to be the chair for this afternoon's session. For those of you who've just had your lunch, welcome back. And for those of you who are new and joining us today, this is going to be a really fantastic session, moving on from COVID-19 vaccination issues and influenza to adult immunisation more broadly. So without further ado, I would like to introduce Professor Tony Cunningham, who really needs a little introduction. He's an infectious diseases physician and clinical virologist, internationally renowned for his research on the immunobiology of HIV and herpes viruses in particular, and he needs no further introduction. So over to you, Tony, to talk on herpes zoster.
Thank you very much, Margie. I'm just going to share my screen. Everybody see the screen, I hope. Margie, can you see that?
Yes, that's great, Tony. Go ahead.
Terrific. Okay, well, that's Westmead growing by the day. And these are my declarations. Always better to advise several companies rather than one. I just want to start off by showing you the out of our recent review that herpes zoster does pack a wallop over the age of 65, and in terms of disability, similar to that of its partner, pneumococcal, invasive pneumococcal disease, to a lesser degree than flu. But it is a significant disease, as anyone who's had it will tell you. So worthwhile developing a vaccine for this disease. Now, we've heard from Stefan Gravenstein today, and so these are just approximate figures of the best you can expect up until recently for immunization in the aging and people over the age of 65. And it's pretty optimistic for flu and pneumococcal immunization, ideal when you get matching with strains. Zostavax was 51% effective against incident zoster, and the vaccine I'm going to tell you about today has the extraordinary track record of a 90% efficacy, completely unexpected for many of us. We've heard Stefan Gravenstein tell us a lot about vaccine response in the aging immunosenescence. And so I'm not going to go into that in great detail, just to indicate that immunosenescence affects all arms of the immune response. It's difficult to put your finger on one. There are some very interesting aspects to it, in that lymph nodes tend to shrink in the aging, and the reticular networks that immune cells use to meet with each other are replaced by scarring. So a little bit like lymph nodes in AIDS. And you can see that many of the aspects of both T and innate immunity, antibody production, are reduced. You get this production of pro-inflammatory cytokines and dysfunctional memory T cells, which contributes to the inflammaging that Stefan referred to. And so this is part of the reason why we reactivate the varicella zoster virus from the dorsal root ganglion or the trigeminal ganglion. It is transported down nerves to the skin and gives rise to the familiar pain and skin rash of herpes zoster. Unlike herpes simplex, herpes zoster causes death to nerve cells and also inflammation in the dorsal root ganglion, which is partly responsible for the pain. And by the time you get to 50, more than 99% of people have had chicken pox. So that means that virtually in high-income countries, virtually the whole population is potentially able to reactivate the virus and develop zoster. And we therefore see that above the age of 50, you get this increase in the incidence of herpes zoster. We did this in Australia with Rainer and others, and you can see in every high-income country one gets this increase, marked increase in herpes zoster up to the age of 80, and post-epedic neuralgia, which I'll talk about later, appears in the late 50s and increases after up to the age of 80. 1/3 of people can expect to get herpes zoster, and by the time you get to 85, about 50% of people can then expect to have zoster in their remaining years. And this is a very painful condition. I'm not going to go into all the features of herpes zoster, just to emphasize the most feared one is that of post-epedic neuralgia or neuropathic pain that persists for more than 3 months and can affect up to 30% of patients with shingles. Ocular zoster, as you know, is a major concern, and anybody with ocular zoster should be referred to an ophthalmologist. And then we've got these other side effects, of which Stefan mentioned cerebrovascular disease, which is now fairly clearly increased within the first 6 months of an episode of herpes zoster. And of course, all of this is increased, more frequent, longer duration and greater disease in immune-compromised patients, and I'll deal with that just briefly later on. Now, as I mentioned, one sees a reduction in all aspects of immunity over the age of 65, but here's an indication of a reduction in T cells to herpes zoster, which are the major controlling factor. The antibodies don't drop, the T cells do. We don't know what the exact threshold is. We do know that it's possible to boost this because Mike Oxman and Maren Levin decided to do this in people over the age of 60 with a concentrated live attenuated virus, really the chickenpox vaccine, and in 2005 published seminal study showing that Zostavax was effective in protecting against herpes zoster and against post-epedic neuralgia. And just last year, we looked at the impact of the introduction of herpes of Zostavax into Australia in 2016 by looking at scripts and other mechanisms of understanding the incidence of herpes zoster. And in those groups between the ages of 70 and 79 who were receiving vaccine through the National Immunisation Program, there was a marked decrease in herpes zoster incidence. So I'm going to talk about the recombinant zoster vaccine, or Shingrix, and this consists not of a live attenuated vaccine, but a single protein, glycoprotein E antigen, and this particular, if you like, spike antigen, a bit like what has been used in COVID vaccines, induces protective antibody, which is directed, again, like COVID vaccines, towards where the virus interacts with its receptor. It also has T cell epitopes in it, so it's an ideal candidate as an antigen. But because we get rid of nucleic acids and lipids, which are immunostimulants, one needs adjuvants. And the one that's been used for Shingrix is responsible for the outstanding efficacy of the vaccine in the aging. It consists of monophosphorylipid A from the cell wall of Salmonella and QS21 from the bark of a South American tree, a saponin, this is a TLR4 agonist, and these are all packaged together, again, like the RNA vaccines of COVID, into a liposome or a lipid nanoparticle. And the vaccine works after intramuscular injection. There is rapid drainage within 30 minutes in mouse models of both components of the vaccine, the adjuvant and the antigen, into lymph nodes, and the adjuvant's taken up by macrophages at the outer edge of the lymph node, and then a cascade of innate immune responses occurs, which ultimately primes dendritic cells, which stimulate CD4 T cells and B cells to produce both antibody and CD4 T cells. Both go up far more than Shingrix, like about 10 to 20-fold more. And just out of interest, we're looking at the mechanism of this, because if we can understand the mechanism of how these remarkable adjuvants work, we might be able to improve still further the ratio of immunogenicity to reactogenicity. So in our lab, in collaboration with GSK scientists, we're using human lymph node models and adding the adjuvant to the outside of the lymph node, and then looking to see what happens to the immune cells and their function and their relationships to each other using pretty sophisticated microscopy methods. So this adjuvant is incredibly effective. Here is glycoprotein E by itself. Hope you can see my mouse. If you can't see that, then it's the right-hand green bars that I'm showing you, and particularly the light green bar, where people over the age of 70 get only about a 10% immunogenicity, but as shown in the orange bars, this goes up to 90% when the adjuvant is added to the antigen in people. And it's really important that 2 doses are given, because you get only about a 67% increase in immunogenicity, about 2/3, whereas it's up around 95% after 2 injections. And you can get them 2 to 6 months apart, which is a bit late for me. I had my first Shingrix injection in Montreal, and thanks to COVID, that was 1.5 years ago, so I probably need a full series again, but you can stretch out that second dose to 2 to 6 months. Now, in the trials, we looked at people over the age of 50, and then enriched them with people over the age of 70, and we ran that concurrently so that we could pool some of the results. And the reason for enriching them with people over the age of 70 was to make sure that we had sufficient numbers of people with post-epedic neuralgia. 30,000 people were studied across the world, and we, to our astonishment, at a meeting in Paris, I still remember, we're all making predictions about how effective this would be. No one predicted an efficacy of 97% in people up to the age of 70, and 91% even over the age of 80, and the 95% confidence intervals actually cross here. So I think all we can say is the efficacy is over 90% in everyone up to and over the age of 90. When we look at the efficacy of post-epedic neuralgia, it's about the same, whether it's over 50 or over 70. And unlike Zostavax, which has additional efficacy against post-epedic neuralgia, most of the efficacy against PHN is against Zoster itself. Similarly, excellent efficacy against all other complications, ocular, etc. And when we look at this over a time course, we can see, compared with placebo in blue and the vaccinated patients in red, they're still diverging at 4 years against herpes zoster and also against post-epedic neuralgia. And this gave us a lot of confidence that this vaccine was going to last. And we do have this problem with Zostavax of falling off efficacy falling well for over 8 years. So with Shingrix, we saw immunogenicity out to 9 years. That's now been taken out beyond 10. And we're just resubmitting the paper at present on an interim analysis at 7.1 years of efficacy. And in the last 2 years, the vaccine efficacy has been 84%. Overall, this is 90.9%. So this vaccine is predicted to last 10 to 15 years, which means you have much more flexibility in being able to give it to people at younger age groups and be assured that you're not going to have to use boosters too often. Not only that, the vaccine is effective in people who have multiple morbidities in the study. We had an average of 6 comorbidities, and it's also effective in people who are affected by frailty. And frailty has been a problem for some other vaccines, such as influenza vaccine. And this is particularly important when one is looking at aging, because Zoster itself can precipitate frailty and admission permanently to residential care. The downside, slight downside, is the reactogenicity, which is pretty high in terms of up to 60% of people developing pain, but only 9 to 10% of people develop pain of a severity to keep them, local pain, to keep them not doing their usual business. And this only lasts about 2 days. And the same with general symptoms of fatigue and headache and myalgia, which are severe again in about 10% of people. People who've had the Pfizer vaccine will relate to this. And the good thing about it is that there is a similar incidence of this more severe grade 3 reactogenicity after the first and second doses. 95%, however, return for a second dose in the trials, and 34% of those with injection site reactogenicity of grade 3 severity after the first dose had the same after a second dose. There's less reactogenicity with advancing age, and herpes zoster in the previous 5 years and also previous Zostavax did not influence safety or reactogenicity. So shown here is similar serious adverse events, deaths, and autoimmune disease episodes between Shingrix and placebo. Now, it's important to talk about immune-compromised patients because, as I'll mention, we are all concerned about immune-compromised people, even though they constitute only about 5 to 10% of the total burden of herpes zoster. So in the most severe form of immunosuppression, hematopoietic stem cell transplantation, the vaccine was 68% effective against incident zoster, 90% against post-epedic neuralgia, and hematologic malignancies, it was 87% effective in people over the age of 18, not over the age of 50, but still high immunogenicity in people with HIV, and pretty good in renal transplantation and solid malignancy. We don't have phase 3 efficacy trial results for this lot as yet. The most important thing is that the reactogenicity was pretty similar to immunocompetent patients, and there were no excess severe adverse events. Now, it can be used as a booster following Zostavax, and this is really important where there's high Zostavax coverage, like in the UK and as in Australia, where we estimate almost 60% of people may have received Zostavax in the appropriate age groups. It's safe, there's no difference in reactogenicity, and you can co-administer the vaccine in the opposite arm, of course, because each lymph node provides a little factory of production of immune response to the vaccine. So it can be co-administered with influenza and pneumococcal vaccines, one each in the opposite arm. In summary, Shingrix is 90% effective against herpes zoster and complications. It's unaffected by age and frailty. 2 doses are required. The compliance in the real-world setting is 75 to 85%. I think the 75% may have occurred during problems with rollout in the USA. We don't know efficacy after a single dose, but I don't recommend it. High reactogenicity does occur, but only lasts a couple of days. Duration of efficacy is 84% or 90%, 7 years, but in the last 2 years, 84%. And we've got to keep looking for autoimmunity and gout. Now, this vaccine has clear implications. A single pathogen protein in an adjuvant can be highly efficacious and more than a live attenuated vaccine. Such a combination may cut through immunosenescence, and it's really important to do research on pathogen vaccine adjuvant immunology to determine mechanisms of action and further develop rational vaccine development. 37 approvals worldwide, now 9 national recommendations. In Canada and the USA, it's the preferred vaccine. I'll show you what NSERS has said recently, and in Canada and in Austria, recommending that the vaccine be administered within 12 months after previous Zostavax or herpes zoster. And the NSERS recommendations reflect that as the preferred vaccine now for herpes zoster, and also 12 months after the herpes zoster or after a previous episode, a previous Zostavax injection. However, if you can't get at Shingrix, because it is going to be expensive and it's only on the private market so far, people should be encouraged to receive Zostavax if it's not accessible. Just my colleagues, particularly Tom Heinemann, Amarin Levin, Arnaud Didier-Laurent, who were incredibly helpful as we churned out the results of the trials. Thank you very much.
Fantastic. Thanks, Tony. That was brilliant. We've got a couple of questions, but we might hold those over to the end and go on to the next talk now. So we're going to hear from Robert Boy, who needs no introduction, on meningococcal disease in Australia. And I understand he is presenting these slides on behalf of Professor Monica Lara, who, you can see her bio in the notes, is a medical microbiologist and director of the Division of Bacteriology and the WHO Collaborating Centre for Sexually Transmitted Infections and Antimicrobial Resistance. So Robert, over to you. And I understand you are presenting on behalf of Monica, is that correct?
That's right, Margie, thank you so much. I've been collaborating with Monica for 15 years and on the topic of meningococcal disease and its prevention. I did forget to say first thing this morning that I recognise the traditional owners of this land and pay respect to their elders past and present, so sorry not to have said that earlier. So now I will share my screen. So the epidemiology of meningococcal disease, especially in adults, has been incredibly interesting and very changing over the last few decades. The germ is incredibly able to mutate, not quite so much as viruses do, but it has many methods of mutating, both simple point mutation through phase variation, homologous variation, and so on. There's substantial genetic variability as a consequence, and we get therefore emergence and then the persistence of different virulent lineages. We go back over the history for more than a century, we can see very clearly that meningococcal disease in Australia, like in many other countries, did peak with the world wars. There were further peaks with other conflicts. And then we saw the very interesting dramatic rise during the 1990s of meningococcal disease. And around the turn of the millennium, we especially got a rise in meningococcal C disease. And at the time I was working in the UK, where they were the first to implement a vaccine in 1999-2000 against meningococcal C. The notifications in Australia and the laboratory confirmations go hand in hand, and they were slightly different earlier because we didn't have a strong PCR, but since about 2010, the number of notifiable cases and the number of cases found clinically and the number of cases found through surveillance has been very close together. And if you look at the pattern, you say, well, isn't this disease going away? And of course, COVID and social distancing has contributed to the decline of disease in the last year or two. But we did have a very big peak in 2017 when there was a concomitant very big rise in influenza disease in Australia, and more on that as I proceed through this talk. So meningococcal B, I say B for babies because it's especially a problem in young children, has been the predominant strain. For a year there, in about 2017, we had just as much meningococcal W disease, and that occurred at all ages, both the young, the old, and adults. And we also, in 2017, had a very interesting surge in all 4 serogroups, not just B and Y and W, but also in Y and C. And the clearest and simplest explanation for that was the high rate of influenza was predisposing to all serogroups going up rather than a particular lineage of, say, B or W being the issue. So if we go back to the problems in the first half of the 20th century, it was predominantly meningococcal A and causing epidemic disease. And there were hypervirulent clones at the root of that. Once herd immunity came in, numbers went down again. Meningococcal B and C came in the second half of the 20th century, and we still had the occasional outbreak of meningococcal A in Central Australia and other parts where Indigenous people were particularly affected. And there were outbreaks too in New Zealand around similar times. So Australia was only the 4th or 5th country to introduce the meningococcal C vaccine as a routine, and you can see that the number of invasive meningococcal disease cases had peaked in Australia around 2001-2. Vaccine was introduced in 2003 and had a very rapid impact on the incidence of disease, to the extent that we hardly see meningococcal C at all now. There's a little blip that I'll tell you about in a particular risk group in a moment. So if we look at the age breakdown of disease, we can see that it really did affect teenagers, young adults, and older adults, particularly in the early 2000s. And the estimated deaths due to meningococcal C invasive disease are shown here. But importantly, and this is a paper written by Glenda Lawrence from the National Centre, and Monica and I were co-authors along with Peter McIntyre, the protective effect of direct and indirect vaccination led to, by 2016, a 99% reduction in meningococcal C incidence. But curiously, without having a vaccine for meningococcal B, that too went down by more than 50% independently. So an interesting observation of a secular trend not driven by immunisation. So looking worldwide, there's been some nice papers from Europe and North America, and they too show similar dramatic declines, 97%, for example, in the UK, in deaths from 78 in 98 to just 1 in 2009. So what about that little blip in 2017? Well, influenza, clearly I postulate was important in that, but also there was the issue that most of the cases were in a particular risk group of men who have sex with men. And And the same thing was happening in the US as well. So, for example, in 2016, over a few months, they had 22 cases, and it was a particular serotype, sequence type 11. So again, there was a virulence clone that was important, but it was also the behavior of people that made them at risk. And we in Australia published, our colleagues from Victoria published on this topic as well. So I'll move on. Then I want to talk a bit more now about meningococcal B, which has really been the predominant problem for the last couple of decades, and had that surge in 2017, as I said. It spiked in 2017, and people went, during the course of the decade, there were multiple applications from the company which had made a meningococcal B vaccine for babies and older children, and they were met with the PVAC deciding that it was not cost effective, despite meningococcal B being the most common cause of the disease, and it having many long-term complications as well. And you can see TV ads about that every day, I think, on television anyway. So there again is the factor of raised level in 2017. And then 2020, I guess if you move that red circle further over to the right, you can see that we've never had fewer meningococcal B cases, and we still don't have routine vaccination. So why is that? Well, the simple explanation, as I've said already, might be the social distancing, might be we're not getting new cases being brought in, being carried in people's throats from overseas, but especially the social distancing, which has reduced viral infection, we suggest has, as a secondary consequence, stopped meningococci that were in the throat from invading into the bloodstream and causing sepsis or meningitis. If we reflect back to the last pandemic in 2009, the H1N1 influenza pandemic, we got a lot of consultations with DPs in the community. And then again, we got a lot in 2017. The 5-year average is in blue, the dashed line, and that's much lower. But 2017, there were a lot. And what when you look carefully at the data, the peak of influenza was about 2 weeks before the peak of meningococcal B. And when our colleagues in the United States explored this potential relationship, they found the same thing happening in 19 out of 20 seasons. So it's more than a coincidence. It's ecological, but it looks very strong evidence, even if it is ecological. So moving on. I've referred already to the product Bexsero, which was taken over from Novartis by GSK. It has a broad spectrum cover, not just of meningococcal B, but some cover against meningococcal Y, W as well. It is registered in Australia for people from the age of 2 months, and it's been available for 7 years by private prescription. ATAGI has recently and happily recommended its use for high-risk groups. So, for example, Indigenous children under 2, and then special risk groups like people with HIV or no spleen or on a drug that decreases the splenic function. Teenagers as well, particularly in crowded circumstances and living in institutions. By that I mean schools, school boarding. They too are at somewhat increased risk and recommended for immunisation, but it's paid for especially for Indigenous Australians. The PVAC has rejected multiple applications, but it's still something that is worth considering on the private market, but it is expensive, as people recognise. Some tremendous research work done in Australia by Professor Helen Marshall and her colleagues out of Adelaide. They ran a very impressive study in high schools, because they had such a high rate in South Australia, particularly of invasive meningococcal B disease. And of the invasive disease, more than 80% was B, and half were in adolescents. So they put together a study which in short was called Be Part of It. It was a cluster randomized, so the unit of randomization was a high school, and everyone got the vaccine or not. And they looked particularly at a more powerful endpoint of nasopharyngeal carriage in adolescents in South Australia. The long and the short of it was that the impact on carriage was not so impressive, but they did see a very important decline in meningococcal B disease. So a very good and important outcome from that study. So what about meningococcal W and why that surge in 2017? It was virulence lineage driven as much as it was also associated with prior influenza viral infection as well. And it too, with social distancing, all the other impacts, has declined. So we actually started studying this when I was, I started studying it more than 20 years ago when I was working in the UK, in the East End, where we had a very big ethnic population of Muslims, especially Bangladeshis. And we saw a lot of disease in children, including pericarditis. That was due to pilgrims who had been on the Muslim pilgrimage to Mecca coming back, and we had only one adult who had disease, but the carriage of the germ spread through the child community, and we had about 10 children who got infected. And that was the biggest local outbreak in the whole of Europe, so it got me very interested in the problem. Of course, it's a much bigger problem in Africa. And for example, in 2002, there were 12,000 cases in Burkina Faso. Again, the sequence type 11 was involved, and a particular protein, a poor A protein, P1.5,2. There are a couple of geographically and genetically diverse lineages, and we published on that with colleagues around the world. But suffice to say that, again, epidemic meningococcal disease reared its ugly head back then, and it's still kept on causing outbreaks in different parts of the world over the last 20 years. So that's an example of the different outbreaks in the last 20 or so years around the world. The hypervirulent W strain is worth mentioning clinically because not only does it cause the classical meningitis and sepsis, it could also result in pneumonia, epiglottitis, septic arthritis, and gastrointestinal syndromes. A former PhD student of mine who now has a prominent role in London published on the added symptoms such as gastrointestinal diarrhea, for example, in cases that were particularly severe. So this sequence type 11 in a report from Shamez Ladani and his colleagues, who I just mentioned. Shamez did a PhD with me nearly 15 years ago, and he reported this in Eurosurveillance. It was also seen in Chile. It's been seen in Western Australia as well. So it's an interesting new way in which meningococcal disease is being recognised, not just the classical symptoms. So I'm coming close to the end, looking yet again at Australia and the breakdown by year over the last 20 years and by serogroup. One can see the changes that happened, especially in the last 5 years or so, with a surge in meningococcal W. The incidence per 100,000 people in Australia is generally around 1 per year. So if there are 25 million, then that's 250 cases per year. We've just observed in the last year, 2020, only 90 cases, so clearly different. And what we've done in Australia is some pretty good things by way of introducing vaccines for at-risk groups such as teenagers. And I really like this set of graphs for different ages. And you can see in the first one, the high incidence in children under 1. But all of the red bars are going up, except for one in 15 to 19-year-olds, because most states in Australia introduced routine ACY-W quadrivalent conjugate vaccine for 15, 16-year-olds. And so the only one you really see a real drop in 2017 is the age group who are being offered routine vaccination in many states. That's a nice piece of data. MenW is made up of a number of clones, as this illustrates. There's some different in America as to North Africa, and the Haj one is part of that as well. So there's ongoing genomic investigation of these clones, and they're mutating as we know they do so well. So by jurisdiction, you can see there what I was alluding to already, the introduction of 4-valent meningococcal C vaccine. And as I've shown you already in a graph, the impact was almost immediate in terms of incidence of disease in teens. So the Honourable Greg Hunt announced this, as he likes to do. And the UK actually noted the problem a little bit earlier than us, and they introduced in August of 2015 an emergency program for adolescents. And they projected that the program should lead to a major decline in meningococcal W disease. And they actually started seeing an impact when only a third of the population were vaccinated. So this is a continuation of the graph, and we can see by 2018 an even greater reduction in disease incidence and notifications in both 15 to 19-year-olds and 20 to 24, and somewhat in other populations as well. So was that a herd immunity effect, or was that a secular trend anyway, or maybe a bit of both? So meningococcal Y, we've said already, surged in 2017 as well. It has been an issue in the last 10 years in Europe as well. And it especially affects adults and older adults. So good that this is an Adult Immunisation Forum. And in Australia, it went from being less than 3% of cases, or less than 5% of cases, to nearly 20% in recent years. So that too is due to a clonal complex. This time it's numbered 23. There's a lot of clustering of cases, local transmission and spread. So this is just a reflection on coronavirus. Shutting down of Australia in different ways, in different places. And what can we speculate will happen? Well, with COVID vaccination on disease rates, and this graph illustrates that some very nice mathematical modelling out of Sydney suggests that if we have 70% of people complying with physical distancing, we can still have problems. But when we get compliance up to 80 and 90%, we can control COVID-19 versions, maybe A, B, and C, alpha, beta, gamma. But Delta is really a great challenge. It's just not what my talk's about, but it's just a reflection on the interaction between respiratory viruses and meningococcal disease more generally. We are currently putting together a paper about this decline in meningococcal disease in Australia and the potential explanations for it. The lowest ever recorded numbers last year. The impact of vaccination against ACYW is, of course, important as well, but the reduction in notifications has continued through into the first quarter of this year. And so maybe we're going to see a resurgence when there's more respiratory viral infection more generally, as social distancing is less well observed in the future. But for the moment, we've seemed to have controlled a disease of meningococcal invasiveness in Australia through a combination of vaccination and also all the mitigating factors we're put in place for COVID. So as was said in the just recently, earlier this month, we've never seen this kind of thing before. So many illnesses have decreased, and what we've seen in nursing homes, and I'll finish on this point, is that We've hardly had any respiratory viral outbreaks at all in nursing homes. We've been monitoring in Western Sydney very closely and avidly and actively 63 nursing homes. We've only had last year outbreaks due to rhinovirus, cold-like outbreak, cold symptoms, just coughing and runny nose and occasional fever, not deadly. And that one seems to have been the hardest to control by social distancing. So, this is Monica's slides, and I recognise her and her team. You can read a lot of people across Australia have contributed to this work, but these are Monica's slides. I'm sorry I can't share them because they're still subject to being published quite soon. So thank you for your attention.
Great, thanks, Robert. That was a tour de force summary of meningococcal disease, and there's some great questions too in the Q&A, which we'll come back to in a little while. So now we're going to move on, and I'd like to introduce Professor Tony Corman. Tony, you can share your slides while I'm introducing you. So Tony's the Director of Monash Infectious Diseases and the Director of Microbiology at Monash Health, and he's also a member of ATAGI. And he's going to talk to us about pneumococcal disease. Thanks, Tony.
So thank you very much to the organisers for inviting me to speak again at this forum. And as Margie said, I'm a member of what was a obscure ministerial advisory group called ATAGI, which has been a bit more prominent of late. I've also given some talks at pharma-sponsored meetings. Now, the Zoom format probably doesn't lend it to asking questions, but it'd be interesting if anyone knew who this bloke was, who wrote some very seminal works in over 140 years ago. His name's George Sternberg, and in this paper in 1885, related to the pneumococcus of Friedlander, he took the liberty of naming it Micrococcus pasteuri. And he thought that it was his right to name the organism because he, in fact, had a few years previously described the organism found in normal human saliva. And it was also found simultaneously by Pasteur in the blood of rabbits, which had been injected with the saliva of a child who died of hydrophobia, also known as rabies, in Paris. And here's Louis Pasteur. He called the organism microbe septicemic de salive. And Sternberg here in his work actually took his own saliva, injected it into rabbits, produced septicemia, which in those days the Americans were still spelling with an AE. Interestingly, later on though, in the following year in 1882, he described a further series of experiments in rabbits. And in these experiments, he injected saliva mixed with certain substances, including alcohol, which, when added in certain proportions, prevented the usual fatal result, and therefore seems to subsequently protect the animal from lethal effects of injection of saline alone, and probably inadvertently was describing the first pneumococcal vaccination. So I'm going to talk about pneumococcal disease briefly, then introduce the pneumococcal vaccines, the polysaccharide, conjugate vaccines, and talk about some future developments. In terms of pneumococcal disease, we can divide into invasive and non-invasive disease. Invasive disease can be associated with bacteremia, meningitis, and pneumonia. And bacteremic pneumococcal pneumonia is a subset of pneumococcal pneumonia generally, which is a subset of community-acquired pneumonia and the most important cause of bacterial pneumonia. I've tried to come up with some new historical facts today, but I won't apologise for repeating and using this slide again. This comes from Robert Austrian and Jerome Gold's paper from 1964, in which they looked at the outcomes of bacteremic pneumococcal bacteremia. And they looked at three groups, and the group down here is the untreated group. And this was a group of patients from Brooklyn who'd been admitted to hospital at the turn of the 20th century, in whom in the pre-antibiotic era, and this is a natural history of bacteremic pneumococcal pneumonia with approximately 85 to 90% death rate. And penicillin, really, you can see here, is a wonder drug. It reversed the mortality so that it was about a 15% mortality overall. Serum therapy with convalescent plasma, which has been in the news as a potential treatment for COVID, was reasonably effective, actually, in reducing the mortality by about 50%, but penicillin was a real game changer. What's very important to note, though, in this figure, is that in the first 5 days, no matter what you gave, whether you gave serum therapy or even penicillin, there was no significant reduction in mortality. So that first 5 days, your cards were marked before you came into hospital almost. And people have said, well, you know, this was back in the 1950s, before the era of modern intensive care medicine, and probably we do better now. Well, not sure about that. This study done from this millennium shows that looking at the number of deaths and graphed against the number of days after positive blood culture, over 2/3 of the deaths occur in the first few days following the positive blood culture. So again, a lot of the mortality is in that very early period. And so, and just like Paul Griffin was talking about treatments for COVID, I think our efforts of trying to vaccinate and prevent disease for COVID and also for pneumococcal disease is the way to go, rather than relying on treatments, even treatments as good as penicillin. So vaccination for pneumococcus. The pneumococcal polysaccharide vaccine has been around, again, different versions for almost 100 years. The currently available vaccine is a 23-valent polysaccharide vaccine, which contains the most frequent or most virulent capsular types of pneumococcus. In general, it's a good vaccine at preventing invasive pneumococcal disease. In randomized controlled trials, 75% reduction in the incidence of invasive pneumococcal disease, slightly less in non-randomized effectiveness trials. But in terms of all-cause pneumonia, it's not as good, but of course, not all pneumonia is due to pneumococcus. Again, it had reasonable efficacy in some low-income countries, but in higher-income countries, and in particular in patients with chronic disease, was not as good. And this is if people are interested in looking more at the data related to pneumococcal polysaccharide vaccines, I recommend this review from Michael Niederman and colleagues earlier this year, which shows that which again emphasises the vaccine is very effective against vaccine-type invasive pneumococcal disease and vaccine-type pneumococcal pneumonia, and can also lower the burden of vaccine-type pneumococcal pneumonia, non-invasive disease. But the protection may be lower in possibly some of the patients who need it most, such as adults aged over 75, people with underlying disease, such as pulmonary disease, and also the effect wanes such that revaccination may be required because the efficacy wanes after about 5 years. In terms of the conjugate vaccines, these are developed by linking the polysaccharide molecule to a protein carrier. And this approach has led to the vaccines being, this is an adult immunisation talk, but importantly, the standard polysaccharide vaccines don't work well in young infants. The conjugate vaccines are immunogenic in that important group who are vulnerable to invasive pneumococcal disease. The conjugate vaccines, as opposed to the polysaccharide vaccines, also stimulate mucosal antibody production and stimulate memory B cells, and they have effect on reducing asymptomatic nasopharyngeal colonisation and reducing transmission of vaccine-type pneumococci. The early polysaccharide vaccines contained 7 of the most common serotypes, and the currently available conjugate vaccine contains 13 serotypes, which were contained in the polysaccharide vaccine, although 6A was not. So the initial data for the 7-valent conjugate vaccine was really excellent. These were introduced around the turn of the millennium in the US. This is US data, and given to infants. And you can see here in the target group of the underage, under the age of 5, you can see here in the red, significant reduction in invasive pneumococcal disease in that group. But you can also see in the green, which was the people over the age of 65, there was also a significant reduction in invasive pneumococcal disease. As an indirect effect, these, importantly, adults were not given the vaccine. If you look at just the group of adults aged over 65, again, the red showing the invasive pneumococcal disease related to the vaccine types, significant reduction in those, but a concerning increase in non-serotype, in the disease due to serotypes not in the vaccine, in particular 19A. So the development of a vaccine with which included another 6 serotypes led to PCV13. And this was introduced in children about 10 years later, around 2010, and again led to a reduction in all invasive pneumococcal disease seen here in blue, and in the disease due to the vaccine containing types in orange here, but clearly not much reduction in black here in the in the other types not included in the vaccine. As a added bonus, the introduction of this vaccine led to the significant reductions in non-susceptible invasive pneumococcal disease. So vaccines are also good at trying to prevent the development of antimicrobial resistance, or the incidence of antimicrobial resistance. And that's both, again, in the target population under 5, but also in the over 65-year group, possibly related to clustering of some of the resistance in certain serotypes which were included in the vaccine. So that's thus far really been talking about the introduction of vaccines in infants. So what about in adults? The seminal study was the Capita study performed in the Netherlands. Almost 85,000 people randomized to receive either the vaccine or placebo. And importantly, the Netherlands was a greenfield site, if you like, with no routine polysaccharide vaccine use in the community. And people were given the vaccine in the community and then followed and had pretty intense investigation if they developed a pneumonia illness or a febrile illness, in particular using serotype-specific pneumococcal urinary antigen testing. The overall results were significant in reducing the incidence of first episode confirmed vaccine type pneumococcal community-acquired pneumonia, and also confirmed non-bacteremic or non-invasive pneumococcal pneumonia, and also reduction in vaccine type invasive pneumococcal disease. This is some of the Kaplan-Meier curves here demonstrating those figures. Smaller numbers for the invasive pneumococcal disease, but again, quite impressive separation in vaccine type community-acquired pneumonia, which was the primary endpoint of the study. This is a follow-up study from Capita done a few years later, which encouragingly demonstrated that antibody titers persisted 2 years following the administration of the vaccine, and that was to all the 13 serotypes contained in the vaccine, and this is regardless of age and comorbidity. So it seems to be have longevity of its immunogenicity. So in the US, and this was recently the ACIP, which I'd certainly recommend people to, if they're interested in the area, to have a look at. And I think you can probably, I'm not sure if this one's on YouTube, but often they are live recordings of their meetings, their deliberations of the meetings, all the data's there, all the slides are put up online, which is fantastic. And Catherine Polling introduced the session and looked at the history of their recommendations. As I mentioned before, the 7-valent vaccine introduced in children around 2000, the 13-valent vaccine introduced in 2010. And following that, adults with immunocompromising conditions were advised to receive the 13-valent vaccine. But then in 2014, following the release of data from the Capita trial, all adults over the age of 65 were recommended to receive the conjugate vaccine in addition to the polysaccharide vaccine. And then in 2019, there was a lot of deliberation. After that recommendation in 2014, they planned to have an evaluation performed a few years later to determine the effectiveness of that and to advise on further recommendations. And the recommendations in the end were to not discontinue and not necessarily continue, but to advise shared clinical decision making between patients and their doctors if they were offered the vaccine with routine ongoing polysaccharide vaccine recommendation. And this is some of the data shown before, but this is showing it longitudinally. The introduction of this is data in adults over age 65, but you can see a reduction following the introduction of the 7-valent vaccine, further reduction following the 13-valent vaccine in children. But on the right of the graph, you can see not a great further reduction after the introduction of vaccine into the adult population. So the indirect effects in children made up most of the gains, and there wasn't that much added benefit of vaccinating the adults themselves. If people are more interested, I've spoken about this in a previous meeting, they can go and have a look at the detailed decision-making related to this, but they looked at the indirect effects, the effects and what additional benefits, and came up with this sort of on-the-fence recommendation. What about in Europe? Really, it's a dog's breakfast. This article details the recommendations in related to age, related to risk-based indications, and different countries have a whole range of different recommendations of different vaccines at different ages. So it really, it doesn't help too much looking at what's happening in Europe. What about the position in Australia? And I think, again, in previous talks, I've gone through the history of this with the polysaccharide vaccine recommended for all adults back in 1997, adults over the age of 65. And then the introduction a few years later in Australia of a universal vaccine in children. But in adults, it's taken a number of years to develop a position on the recommendation for adult routine conjugate vaccine in elderly. And in the end, last year, it was decided that all over 70-year-olds with lower ages in Indigenous populations would be recommended to receive the conjugate pneumococcal vaccine along with Zostavax age 70. So increase from 65 to 71 dose. So busy recommendation, but if you just look at the top right corner, with non-Indigenous adults aged over 70, recommended to receive 1 dose of pneumococcal vaccine. And after a lot of excellent work from a number of people, including Chris Blythe and others who've spoken at this meeting before, importantly, that anyone over the age of 12 months, children and adults with immunocompromising or other risk conditions, were able to receive a single dose of the conjugate vaccine, followed by polysaccharide vaccine for the high risk people. But for an individual aged over 70 without this significant risk, just to emphasise, they're recommended just to receive the conjugate vaccine at the moment. And I'm sure a number of you would predict some of the potential issues related to this, and an excellent article, including our chair, our co-chair, and others, Rob Menzies, who's spoken in this forum previously, have looked at some of the Australian data, and I don't have time to discuss the issue of Indigenous rates of pneumococcal disease, which are extremely high, and hence some of the differential recommendations. But just focusing on the non-Indigenous groups, you can see higher rates as you get older, in addition to the younger age group. And this is some of the local data. So maybe just concentrating on the age 65 plus, on the right figure, again, after the introduction of the 13-valent vaccine in children, we've seen not a great deal of difference in the rates in adults. And in fact, if you look at the green circles, down the bottom, you can see increases in non-vaccine serotypes, including serotypes included in the polysaccharide vaccine. And so that's Indigenous and non-Indigenous. And again, some detailed numbers of the the vaccines, in particular, the increase in serotype 3 as a proportion of cases, which is not included in the 13-valent, or is not particularly well covered by the 13-valent vaccine. So the authors have suggested there was a potential benefit in possibly adding or maintaining the polysaccharide vaccine, possibly in combination with the conjugate vaccine. So certainly an area of debate. Just to go back to the US now, and again, excellent slides here looking at the future. They've got data on their serotypes, again, in the over 65 group, serotype 3 in the green here, very prominent. They looked at issues related to pneumonia, and again, there are some opportunities to prevent additional disease burden amongst adults, possibly with new pneumococcal vaccines, which I'll talk about in a moment. In terms of coverage, their coverage still remains pretty low in some areas, especially in some particular risk groups. And so just to finish off with some further developments, we've got the 7 and 20, and there's a development now of a 15-valent vaccine, which contains 2 important extra serotypes, a 20-valent vaccine with another 7 serotypes, and even a 24-valent vaccine. And again, there's at the ACIP meeting, there was presentations both from Pfizer on the quite significant progress that's been made with the development of the 20-valent vaccine, which is pretty well tolerated, good immunogenicity data across all ages, and some plans for some pretty significant studies in the adult group, sort of similar to the Netherlands study, which we'll await with interest. And also a presentation from Merck on their 15-valent vaccine with robust immune responses, in particular superiority against serotype 3, which I've mentioned is quite prominent both in the US and also here. And some again, promising work looking at further studies. So they've also looked at modelling the introduction of these vaccines already, which may well be coming to be available to the market in the next couple of years. Looking at some of these question marks, should we be routinely recommending these vaccines for older people, in younger people with underlying medical conditions, and with or without the polysaccharide vaccine still, because there's still a few serotypes which may be missing, and looked at a few options. So probably like to stop there. Hopefully haven't gone too far over time. Thanks everyone for their attention, and happy to take some questions later in the soon after the next speaker.
Thanks, Tony. That was terrific. There are quite a few questions for you, specifically around the sort of recommendations around PCV13 in the over 70s and the over 65s, but we'll come back to those. But I'd like to introduce our last speaker in this session, Professor Mary Louise Mcclause, who again doesn't need a big introduction. I think we've all seen her providing expert COVID commentary as an epidemiologist in the media. She's a member of the WHO Health Emergencies Program of Experts Advisory Panel for Infection Prevention and Control Preparedness, Readiness and Response to COVID-19. But actually, Mary Louise is going to be speaking to us today on pertussis vaccine in the over 50s, which will be fantastic. So over to you, Mary Louise.
Thank you very much. Good afternoon. Now, I understand that many of you are across different professions. Some are GPs, excuse me, some of you are in pharmacies injecting. So I'm going to give you an overview, just remind you about pertussis. I'm not going to try to tell you a whole bunch that you already know about the microbiology of it, and give you an insight into an adult patient. But first, I'd like to acknowledge the traditional owners of where I work with the Bedigal people. I'd like to acknowledge their custodianship of this land, and my respects go to the past, current and future leaders, and of course to all of our Indigenous and Torres Strait Islander participants today. So we're going to call this particular adult patient Elaine. And then we're going to talk about maybe how we can get Elaine to understand that she might need a vaccine. So we know that pertussis is often called whooping cough, and it's caused by bacteria called Bordetella pertussis. Your symptoms come around about 7 to 10 days after exposure. And it starts off with a runny nose, maybe a bit of mild fever, and you may dismiss this. And then the cough gets worse and it persists, and it's particularly bad at night. And then you might wonder why the rest of the family aren't catching it. So it can last for many months. You're most infectious for the first 3 weeks. And of course, there are lab tests that provide confirmed diagnosis, and that includes a rise in titer fourfold of antibodies, or at least a very large, high titer for IgA. It could be, of course, identified by immunofluorescence or a clinical diagnosis of persistent coughing with usually either a whoop or a vomiting, for example, and a probable exposure. So Australia experiences an epidemic every 3 to 4 years, and this very nice graph from the AIHW, the Australian Institute of Health and Welfare, shows this very nicely. It, as I mentioned, is most infectious in the first 3 weeks. If you can get it early and know what you have, which is often with babies because it's so severe, you can give antibiotics, but that's not necessarily the case in adults because they have no clue what they've got, because it usually presents differently, which I'll explain in a moment. About 50-50 maybe of adults and children, but that changes per year. Every year it might change. And as we can see in this nice graph, by age, you can have quite a difference in the amount of children versus adults. Of the admissions, the hospital admissions, a couple of years ago, it was around about 450 due to complications, and a third of those are babies. And sadly, about 50% of those babies are less than 12 months of age, get hospitalized with complications. They usually die of complications, 1 in 100 babies of pneumonia and brain damage. The death rate has dropped severely, which is great, since the 1940s, when it was nearly 300 per year. And they, of course, may have been underestimated because, of course, the diagnosis may not have been as accurate. It was about 16 per year between the 40s and the 90s. And then from 1997 onwards, it's about 2 per year. However, there's an awful lot of comorbidity just a very difficult time that can go on for at least 6 months in an adult. So from 2018 to 2019, the numbers increased, as you can see on the graph. And last year, confirmed, lab confirmed, which is different from clinically confirmed, there were over 3,000 cases. So let me describe an adult case. Let's call this young lady, let's call her Elaine, as the rabbi was explaining to the audience of a well-known TV series. And I don't know about you, but my kids grew up with this series. And the rabbi goes on to talking about Elaine, and it became more and more obvious who Elaine was. So let me see if you can pick out who Elaine is in this particular wake-up call. So Elaine's background: she was the director of healthcare infection surveillance system. So you would have thought that she had a clue about Bordetella pertussis. And she used to be a microbiologist a long time before that, before she became this director. She taught second-year med students the public health response to respiratory infections, and that included understanding notifiable diseases, which whooping cough is, the vaccination regime, which she might have forgotten, and of course, the importance and the impact of respiratory infections. She was also a director of an offshore master's program in Asia. So that at the time that she became sick with what she didn't realize was whooping cough, of course, she went over to Asia to have lectures, to give lectures to postgrad medical students, but also took research meetings with their Department of Health. So potentially spread. And it was early on. Now, she's not the only DIL, because recently the Immunisation Coalition interviewed just over 25,000 participants on telephone and online. And what they found was staggering. And I've put their findings in the negative to show you how staggering it is. 72% of those 18 to 54 years of age were not aware of whooping cough. Of the unaware, 65% of females were unaware and 71% of males interviewed were unaware. Not a great difference, and possibly because mums may be more inclined to look after the immunization of young children. That might account for a bit more awareness. Shockingly, 60% of the 45 to 54-year-olds were unaware of whooping cough, completely out of their mind. 62% of 35 to 44-year-olds unaware. And not surprising when you start leaving home and become, of course, independent of your parents worrying about your vaccination. 88% of the 18 to 24-year-olds were completely unaware. So this particular DIL was in the 45 to 54-year-old group, that 60% who was unaware. So Elaine, her history was that she should have known better, but she'd forgotten about her booster. And the booster shots are about 85% effective against typical whooping cough, and about 75% against mild cases. It's made from purified proteins, so not killed bacteria, so it's very safe. 1 in 5 may get a fever, and only 1 in 10 may get a local discomfort at the injection site. So 50-year-old, completely unaware professional, persistent cough. It went on and on. One night, I'm told, Elaine told me that her husband grabbed his pillow and said, "Will you just stop coughing?" And apparently the penny didn't drop. So this particular patient was very, very busy, and obviously too busy to look after her own health. So she got whooping cough, but didn't think about it. Apparently, after talking to Elaine, she told me that she noticed her kids weren't getting sick. Her husband wasn't getting sick. Nobody at work was getting sick. And apparently she thought, maybe I've become like my mother. Maybe I'm getting some asthma, and ignored it. Yes, the cough was worse at night, and ignored it. And one day, apparently, Elaine told me that as she was driving to work, she coughed so much that she vomited into her beautiful new suit. And then the penny dropped. She got to work, and a mate of hers up the road, who ran the microbiology department and was co-director of her surveillance unit, heard her coughing on the phone that same day and said, "Mate, do you think you got whooping cough?" And she said, "Well, I vomited into my lap, so I think I do." And then she went to get tested. And of course, the results came back positive. So 77% of those that were interviewed by the Immunisation Coalition were unaware of how this spread. So Elaine started thinking, apparently, about all the people that she might have infected. So she had to do a class-wide and work-wide announcement. Fortunately, because she was in Australia, she didn't cause any infection. 71% of people in her age group, the 45 to 54-year-olds, were completely unaware of how it spread. 70% of the 35 to 44-year-olds were also unaware, and a whopping 92% of the 18 to 24-year-olds were unaware. Of course, remember, their parents have been looking after their vaccination, and it has completely gone out of their brain. And most Australians do not hear about whooping cough, don't see a patient with whooping cough. Now, Elaine tells me that she was at a indoor swimming pool, sitting next to a child in a pram that kept coughing. And apparently, Elaine thought that this child may have had some sort of infection and, epiglottitis or something, but didn't think that this child could have whooping cough and perhaps she could be at risk. So how do you give this wake-up call to people like Elaine? Well, a whopping 82% of people who were interviewed did not know about a vaccine. 75% of the 45 to 54-year-olds didn't know. 73% for the 35 to 44-year-olds didn't know about a vaccine. And nearly all of the 18 to 24-year-olds didn't know about the vaccine. Had they ever been recommended a vaccine by their GP or pharmacy? 76% said no. 68% of the 45 to 54-year-olds were not ever offered a vaccine, and so forth. And of course, a whopping 94% of 18 to 24-year-olds were never offered it. Were they aware that they needed to have a booster every 10 years? Well, Elaine should have been aware. Now, you can't have people like Elaine reaching that middle age without having had a booster. And 89% were unaware of all of those that were interviewed, 85% in her age group and 95% in the 18 to 24. So how do we capture people like Elaine and the others? Well, new kids get captured all the time by their parents. And of course, it's no wonder that that younger group, 35 to 44 years of age, understood. They were young parents. But that 18 to 24 years of age haven't yet become fully aware of their own responsibilities. And don't forget, they may not go to the doctor very often. Yes, the women might go to get the prescription for the pill, but maybe the young men don't need to go very often because they're terribly fit. So it's going to be tricky. And so perhaps we need to think around this. When you're giving an annual flu injection, maybe remind them. But sadly, the 18 to 24-year-olds haven't previously become aware of the need for flu. The grandchildren talk to the pregnant women. Get your parents vaccinated can help. The grey nomads usually go and get their prescriptions before they start getting into their VW and their camper van and go out there and have fun in Australia. That's the time that their healthcare worker needs to say, oh, by the way, you should get vaccinated because often late spring, early summer can be a real peak for this disease. And then the opportunity for anybody that needs to have a tetanus injection because, of course, they've had an injury, may be an opportunity. But the other way you can capture them is their upcoming birthday. So you're 50 years young and I have a present for you. Yep, you still got it and you still need to get it. So happy birthday, here's a little boost. Perhaps that's the way that we can make 50-year-olds realize they're not old, they're not has-beens, but they certainly are at risk of whooping cough. So please explain to them that whooping cough is awful. Elaine told me that it took her 6 months She'd lost a lot of weight. She couldn't eat because, of course, when you're coughing and, of course, vomiting into your suit lap while you're driving to work, that doesn't help being able to eat. And apparently she went down 2 sizes in her clothing, and it took her ages to get back to feeling normal. So you need to tell these 50-year-olds that they could do better in life than having whooping cough. Thank you very much for listening. Oh, and did you work out who Elaine was?
It had to be you, Mary Louise.
And indeed it was.
It looked like you in the photo. And we were having a little chuckle. Thank you. That was a great reminder on the importance of pertussis vaccination for adults. I'm used to speaking about it with regards to maternal vaccination and the impact for infants in the first 6 months of life. So that was a great reminder. Okay, well, we've had 4 fantastic talks. Now we're going to move into the Q&A session. Before we do that, though, I would like to apologise for omitting my acknowledgement of country, and I would like to sincerely acknowledge the traditional owners on the lands on which we're all meeting today, which for me is the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging. All right, so I think we will get started on some questions. Tony Cunningham, we'll start with you. We've got a number of fantastic questions. The first one was actually from Sandra Gaysford, and she asks, is there proof that the AstraZeneca vaccine triggers an attack of shingles, because several patients have been reluctant to have their COVID vaccine due to this rumour? What would you say to that?
It's addressed on the TGA website. One of the advantages you have of a bit of a gap between presentation and the answer session. But the answer is that the number of cases of herpes zoster in AstraZeneca recipients is less than the expected in Australia, and the same is true around the world. So no evidence so far.
Fantastic. So in terms of the number of doses required for boosting with Shingrix after Zostavax and the timing of those doses?
Yeah, I mean, the Myron Levin did this about 5 years afterwards and found that after 5 years, in essence, T cells had subsided to virtually pre-vaccine levels with Zostavax. But in essence, you've got to have 2. It's a completely new vaccine with a different adjuvant, and we know that 1 dose is insufficient. So at least until we see further studies, the answer is 2 months apart or 6 months apart.
And timing after the last dose of Zostavax?
The recommendations from Canada, Austria and NSERS are 1 year or more. The trials were done at 5 years.
Okay, excellent. Now you mentioned that if possible to try and get Shingrix at the same time as your flu and pneumococcal vaccines. Do you recommend that people have those all at the same time?
Difficult with unless you have 3 arms, isn't it?
Exactly. I was wondering how you were going to do that. But certainly all 3 vaccines at the same visit, you don't have a problem with that?
Well, you're supposed to have them in separate sites because, as I said, we're in a data-free zone here. The data suggests that if you actually have one or other of influenza or pneumococcus with Shingrix, then it's fine. One thing you don't do, by the way, is have the adjuvanted vaccine for influenza with Shingrix at the same time, because there's no good data on that. So that's what I said, it's difficult unless you've got 3 arms. So you may have to separate one of those. Presumably it would be pneumococcus.
Yeah, okay, no, good. I thought you might be recommending you could have flu and pneumococcal on one side and Shingrix on the other. There's
no evidence for that one way or the other, and I think I'd prefer, particularly given the pneumococcal issues, and Tony can comment on this, I think I prefer to have really good responses to both and be assured of that. We don't have data, really. On both.
Corman, would you have a view on that? Whether you could give?
Yeah, I think I just looked it up. The excellent immunisation guidelines, which I recommend everyone to look up, does say that you can receive either pneumococcal vaccine alongside Zostavax. It doesn't talk about Shingrix though.
Okay.
But I think the recommendation for age 70 is to get your Zostavax and your pneumococcal conjugate vaccine as a sort of birthday. We talk about a birthday present at aged 50 with Pertussis, and your 70-year-old birthday present. So it's a combination of pneumococcal and Zostavax.
Yeah, Shingrix, you mean? I'd have Shingrix. I would have Shingrix at 60 because that's when it goes up. And I think the NSERS guidelines say above 50, but certainly no later than 60, I would say. And we have had these discussions at GSK about the importance of the lymph node as being the site of action of immunogenicity of vaccines. So I wouldn't like to burden one lymph node, one set of lymph nodes in the axilla with two vaccines without definitive evidence that it doesn't impede. Yeah.
Tony Cunningham, another question that has come up, actually hasn't been put in the chat, but is around recurrent shingles, and whether people who've had recurrent shingles, say, but well before 50 or 60, what is the impact of Shingrix for those people?
Not been done. Recurrent shingles is more common than people envisaged. Certainly the younger you get shingles, the youngest I've seen is 7, and the youngest that I'm aware of reported is 3 with neonatal chickenpox. So it's a very good point. It hasn't been done, and the recommendation is for over the age of 50. We don't know. I've recently seen cases of recurrent shingles in the eye, which is really disturbing. It's not simplex, it's actually zoster. And as soon as I was aware of this case, which actually occurred in Melbourne, I was consulted on, there was a paper that just came out about recurrent ocular shingles. So the answer is we don't know. You'd think it might be actually useful. There may well be immune dysfunctions, specific immune dysfunctions in people who get frequent recurrent shingles. We know with HIV, for instance, in the days of immunosuppression, that recurrent shingles and also shingles in odd dermatomes was characteristic of that particular disease. Yeah.
I thought it might be able to be looked at as a subgroup within the trials, given the number of participants that you might have been able to look at that, but
no, unfortunately. The other thing, of course, unfortunately, in the trials is we had that many patients, subjects in the trial, that many antibody tests, and that many T-cell tests. So they actually diminished, and we weren't able to even establish, because it was such a successful vaccine, we weren't even able to establish, we've tried again, establish a correlative immunity, which we would have loved to do with T-cells. Yeah, that would have given us, if we'd had a correlative immunity, then of course you could do some of these studies on the basis of immunogenicity in terms of immunobridging, etc. But no.
Certainly a very exciting vaccine to hear about Shingrix. Amazing, incredible data. So thanks so much. Okay, Robert, moving on to talking about meningococcal disease. I'm sure you've seen the question by Ginny Mansberg, the $1 million question. What makes Neisseria meningitidis escape the nasopharyngeal mucosa and become pathogenic?
Yeah, we published on this 20 years ago in the British Medical Journal. We ran a study in 150 survivors of meningococcal disease who were teenagers and had matched controls, and looked at biopsychosocial factors, and here are the 3. Having a prior viral ILI in the 3 to 5 days, much as I talked about. So would flu vaccination prevent that? Well, another study published by another group showed that you'd probably need to vaccinate 1 million people against flu to stop 1 case of meninge. Secondly, the behavior of mouth kissing, French kissing, whatever you want to call it, sharing of saliva and of microbes. And that too had an odds ratio of about 3, highly significant. Thirdly, we did a separate paper and looked at the issue of smoking and whether it was exposure to a smoker or to the smoke. And we clearly delineated that it was exposure to a smoker, and they carry meninge more often, and they cough, and they transmit. So a risk factor for teenage meningococcal disease was being exposed to smokers. There are a couple of other things. Could I answer another question while I'm at it?
Yeah, sure, please do.
There was a question about 1-year-olds and babies.
Yeah, I was just going to get to those, the recommendations for Bexsero and MenACWY. So go for it. You can answer them both at the same time.
So firstly, ACYW, I was concentrating on adolescents and adults. So I didn't mention in detail that around the time that teenagers were being recommended and paid for routinely to have vaccination at high school, there was also a move to have 1-year-olds get a single dose of ACYW quadrivalent conjugate vaccine. And that too, of course, had a big impact on the disease rate in 1 to 4-year-olds. Under 1, it isn't recommended. And the question is, well, isn't there W disease under 1? And there is, and B disease. So I did allude to the fact that data from the UK has shown that if you have the meningococcal B vaccine for babies from 2 months of age, there is some cross protection to W. So there's one way out of protecting babies against more than one serogroup. As to the question of cost benefit and the reason that Australia hasn't gone ahead with a routine recommendation for serogroup B vaccination in babies from 2 months of age, it has primarily a decision based on cost, but there's a lot of hidden concern there. First of all, we've just published this year a paper on the long-term complications of meningococcal B disease, and there are new complications that come 5-10 years later. Some people, babies get outgrowth of one of their bones and need repeated orthopedic surgery. Some people get depression. Some people, I'm in touch with 2 young women, older teenage, early adolescent, both of whom had disease 2 or 3 years ago, both of whom have had family members donate a kidney because they got chronic kidney disease. Their kidneys shut down and never recovered. And these are incredibly expensive complications of the disease. So when deliberations are made about whether a vaccine is worthwhile, it's not just about the immediate hospital costs. There's a lot of medical costs in the long term. And I think it's something that needs to be revisited from time to time, because the United Kingdom has been incredibly successful since 2015 with a routine meningococcal B program for babies from 2 months of age. They've controlled their disease and they've made a huge difference to the epidemiology and to the complications.
And also, of course, bears concern, especially for families if they are considering vaccinating under 12 months, and that's then 2 doses 2 months apart and a booster at 12 months at $120, $130 a dose. That's a lot of money, especially if they have more than one child. So that's something that we struggle with in our paediatric consultations in our immunisation clinic when families can't afford Bexsero. So I think that's a really good point, Robert. I wanted to ask you, of those 90 cases in 2020, whether you could comment on the epidemiology, like the age that they occurred in. Were they in the under 1s and the over 65s, or the serogroups? Do we know that data?
We do. I'm not sure whether there was a slide that spoke to that. It is a widespread, with the predominance in babies first to 2 to 3 years of life, and another smaller blip in older teenagers, last year of high school, early university. And there is also some disease in effectively people of grandparent age, 50s, 60s, and it's more commonly W and Y in older people, and B for babies, as I said many times, is overall B is predominant, more than half of cases. So it's.
So that was those 90 cases. That was the data for those 90 cases.
90, yes. Yes.
Okay. Oh, right. Okay. All right. Excellent. All right. So Tony Corman, we might move to some questions for you, if that's okay. So Michael Woodward was asked, how can we recommend PCV13 in adults when most of those serotypes have disappeared due to childhood PCV vaccination? What would you say to that?
Yeah, I think we probably need a whole afternoon to discuss the history, the tortured history of conjugate vaccine. I think in a previous meeting, I did go through that, and it's difficult reading. It really is complicated. And some of that is related to cost, as what Rob was talking about with meningococcal vaccine. I think I've probably tried to highlight some of the issues, and I don't think there's an easy answer to that. I think it's still very beneficial in giving it, but the question is about the role of polysaccharide vaccine, which may provide further protection.
Okay. And can you speak a little bit about the recommendations? So PCV13 is now recommended for those over 70. So for patients over 65, they still recommended to receive Pneumovax 23.
Well, they're sort of a forgotten group, the people between 65 and 70 now. So, I mean, technically, the polysaccharide vaccine is not recommended now. So it's sort of, I suppose, according to the guidelines, you wait till you're 70 to get your conjugate vaccine. 70, the new 60 anyway, Margie, is that right?
Oh, okay. Because there were a couple of questions around
that.
No,
I know, and I think it is. I think it is problematic because prior to last year, people were 65 and they were getting polysaccharide vaccine. I think they were also then eligible for free flu vaccine. Also, they were age 65. Yeah.
But particularly if they're immunocompromised as well, Michael.
Well, immunocompromised is slightly different, as I said. So any immunocompromised person, according to that list, from age 12 months and above, are actually eligible to receive both conjugate and polysaccharide vaccine at the highest risk people. Yeah, but for the people with normal risk, it's shifted to 70 years at the moment.
Yeah. Can you comment on why cardiac disease has disappeared?
I'm pretty sure cardiac disease is in there, so it is on that list. I'm not sure if it's specified, so I think it is on the list. Cardiac disease.
Okay.
Yeah.
Michael's also asked, does the addition of extra serotypes on PCV, so PCV20 or even PCV15, reduce the immunogenicity for the individual subtypes? Yeah,
it's a really good question. And the data, so I think initially there were some issues just with the chemistry, getting the stability of the product. And they said, oh, we're never going to be able to get more than X amount of serotypes in there, but they've been able to now overcome those issues. And I understand the immunogenicity is excellent for the serotypes that are there. Maybe Rob, I'm not sure if Rob wants to comment on that as well, but my understanding is that the data looks pretty good.
Did you want to comment, Robert?
No, I don't. Sorry.
Okay, that's fine. Okay, so Mary Louise, there was a question about maternal vaccination against pertussis and whether that would reduce the need for vaccination for older folk with maternal vaccination, reduce disease in infants.
That's certainly the case, and that's a recommendation. However, if you think that will stop the elderly from getting it, what might fail there is not just family clusters, but acquiring it outside the family cluster. So it's, the grandparents can bring it in to that newborn child, and the to-be grandparents can bring it in to the pregnant woman, but it's already there to remind GPs to vaccinate their female patient planning to get pregnant or pregnant. But yeah, those that are first-time grandparents and first-time parents need to understand that the risk also comes from outside the family cluster. I mean, my case, Elaine's case, is classic. Didn't have grandchildren because her children were too young, and was sitting next to what she believes to be her source, which was somebody else's child. So, yeah, I think, excuse me, I think I don't have pertussis anymore. I think that won't be enough. So I certainly think it won't be enough to protect the grandparents if that's where the question's coming from. Tony, what are you trying to do?
I just want to make a comment that we've been, I think, very successful with maternal vaccination. Yeah, and, we have a lot of referrals from prospective grandparents who've been warned off even seeing their prospective grandchildren if they haven't been vaccinated. So I think we're doing a really good job with our pregnant women and being evangelists for pertussis vaccination, sometimes possibly a little bit too evangelistic with that. But I think it has been very successful. And it's interesting, you know, I presented data from pneumococcus about, again, the older age group being influenced by infant immunisation for pneumococcus. So there's some parallels there in terms of the risk groups, I think. But I think we can use the pregnant women to help us get to the older, to their parents, mate.
Yeah, and to
That's right. However, there is also the issue of we are a very dynamic population with before COVID, with people coming in and out of the country, and not every child has had a vaccine or every pregnant woman necessarily. So we will see circulation even if it's low, and you just need one Elaine to acquire it, and then she may spread it to others. But certainly Tony is right. The vaccination in women is great, but we're failing. I mean, I have a fabulous GP, but I guess he probably thought that I'd remember for myself. And so we need to have a system in place where that burden of memory is not on my GP and certainly not on Elaine, but there's some automation of that memory. And I noticed that Linda has put up a really good suggestion that it could be in the Australian Immunisation Register.
You mean pregnancy status?
No, I mean being 50 and needing your booster. Yeah.
Robert, did you want to make a comment?
Can I just add to what's been said? We've worked with the mothers and fathers of babies that have died, and they've been incredibly great advocates for maternal vaccination. Of course, we as health professionals have done a good job too, but the key point that happened with Malcolm Turnbull was he invited a mother of a baby, Dana, who died, and they had a one-on-one conversation, and she was so articulate that she convinced him, and that was the final straw, or rather the final clincher for us to get routine pregnancy vaccination against pertussis paid for and available. And what I've been saying for a long time is that parents at around the age of 25 should be getting their booster because they're planning children. And then exactly as Louise has said, around the age of 50 to get a booster because you may be going into a grandparent role.
I wanted to ask Louise about the interval of whether you think 10 years is too long for booster doses or whether it should be 5 years if you look at the antibody waning studies.
Look, that's outside my area of expertise. What I did notice was I was probably one of the early cohorts in Australia vaccinated, and my husband's antibodies didn't wane, and he's older than I am, so he didn't acquire it. And I think it's unpredictable, but I'd defer to the experts in the antibody testing regime.
Yeah, Robert Boyd, do you want to comment on that, whether you think the interval of 10 years is appropriate for booster doses for pertussis vaccine for adults?
Thank you. I will comment. DTP is given to adults in lower doses of diphtheria with an aim of maintaining protection. But quite honestly, you probably only need 5, maximum 6 doses of tetanus toxoid in your life to have long-term protection. So it comes to a point where do you just have an acellular pertussis booster? And I think this is an area of potential interesting research, and harking back to my earlier talk about nanopatch, putting such a thing on a nanopatch, just acellular pertussis, would allow you to boost more specifically young parents and uncles and aunts when someone's had a baby, or before they've had a baby indeed, and also grandparents. And if it were on a patch, it would be so much more simple and wouldn't carry the risk of side effects to the diphtheria or the tetanus form of the vaccine.
Yeah, no, that's good. I just wanted to echo also the comments you made, Tony Corman, about the messaging to pregnant women really should be around, you know, the best protection they can provide to their infant is through maternal immunisation, and to not have this kind of aggressive standoff if grandparents aren't vaccinated. I'm not saying that that's not important, but certainly I think we need to just encourage maternal vaccination. And of course, we can all see how effective the program has been. I can't remember the last time we've had an admission at the children's, certainly not in the last 12 months for an infant under 6 months with pertussis, which is quite extraordinary. So it's been a very, very effective program. So I think we've got time for a couple more questions. Before I keep going, do any of the panelists want to make a point that they feel they haven't had an opportunity to make, or address any questions? I think I've managed.
Can I make one comment?
Yeah.
The Immunisation Coalition for the past week has been running a campaign. Many of us, Louise, Ginny Mansberg, Paul Griffin, myself, Gary Groman. The campaign is to give back, pay forward. If you've had a COVID immunisation, why not give to UNICEF so someone else in the third world can have their vaccination paid for? And in 10 seconds, we've already raised $45,000. Hundreds, if not 1,000 people have donated. And it's all about ordinary people paying $10 to vaccinate one person, or $100 for 10. It's that cheap. You can find it on a, here's the ad. You can find it on a website. If you just go to Immunisation Coalition and then click on that, you'll see the donation comes up straight away. It goes directly to our friends at UNICEF Australia. They set up the website. We're just the conduits and the communicators. There's no money passing through our hands. And we want to encourage other people to say, hey, I've been vaccinated, I got it for free, I want to pay back and pay forward.
Oh, that's brilliant. Congratulations on that, Robert. That's fantastic. I think we've got time for a couple more. So Tony Cunningham, there's a question, how soon after the Shingrix should I have my COVID-19 vaccine? What's the recommendation there?
2 weeks apart.
2 weeks.
2 weeks apart, yeah, at present, until we have data which shows you can get them in both arms, yeah.
Question 2. Margie, if I could ask Tony a question about availability of Shingrix in this country.
Well, I don't think it's availability that worries me, it's cost, Tony. You know, it's $250 a pop, and I would dearly like to see, speaking only to the Immunisation Coalition, there'll be and somebody's asked about when Zostavax may, and now that NSERS is that Shingrix is the preferred immunisation, it would be very nice to see successful negotiation between government and company to try and get the cost down and to get it onto the NIP. This is a very effective vaccine. And there is health economic data out there which has been well presented at ACIP that applies to the USA. I haven't seen similar health economic calculations for Australia, but that's probably needed.
Tony Corman, did you want to make any?
You can go to your pharmacy, and I guess I'll be going there because I had mine a year and a half ago, and I'm probably going to need 2, but I'm going to get it.
All right, well, thank you everyone for the fantastic question and for answering all those questions. And we're now going to move on to the next speaker. So thank you very much, Tony and Robert and Mary Louise. It was a pleasure. All right, so I would like to now introduce Professor Raja Dar, who I think is just going to join us. He's going to come in now. Is he in? I can't see him.
I'm there.
Oh, you are there. Oh, excellent. Welcome. Fantastic. Lovely to see you. So Dr. Raja Dar is a pulmonologist and a critical care specialist who currently works at Fortis Hospital in Kolkata, and he holds a director role with the Asia Pacific Alliance for the Control of Influenza. And you're going to share insights on COVID-19 in India is at the coalface. So welcome and thank you so much for joining us.
So thank you very much. Thanks for the invite. It's a pleasure being with all of you today. I was given the topic of COVID-19, the Indian coalface. I was not 100% sure what the topic meant. So I've interpreted it as being a brief account of how we handle the pandemic in India. We've just come to the tail end of the second wave, and the second wave has been nothing like anything I have seen before today. So what we're going to do is to talk about where we are today. We'll talk a little bit about our preparation before the first and second wave. And I want you to notice the heterogeneity that is something that you presume is normal in a country like India, and what the challenges of this heterogeneity as far as healthcare facilities are. Of the total number of patients throughout the world. So that's 17%. However, if you look at deaths, the number of deaths compared to the number of deaths globally is about 10%. Now you have to take into account that the number of deaths in India are an underestimate. We've excluded number of patients with COVID and with serious comorbidities who've died, and we have ascribed them to the comorbidities. Whether that's the right thing to do is an open question, but I guess our numbers have been lesser as compared to some of the more developed European countries, and we'll try and look at the reasons that might be for that. But the 10% is probably a little lower than what you would suppose it's going to be. So how did we prepare for the pandemic? And this includes steps that we've taken in the first and second steps, and second wave, and I'll sort of take you through it in a hurry, because a lot of it is things you know, which you would have done in your own country. The reason for presenting is this because there's a lot of variability in how we prepare in this country as compared to a developed country. So the greatest challenge that we faced was in triaging the patients. And this is just because of the sheer numbers we had, the magnitude and size of the country, and like I said, the amount of heterogeneity we have as far as healthcare services are concerned throughout this country. So when we started off triaging, we started doing something which was unfamiliar territory for us, even in the big metropolitan cities, which was trying to set up telemedicine facilities, trying to set up online consultations, something we have done before, but done in much smaller numbers. And this was aimed at patients who were in home isolation. These were patients with mild symptoms, and going into the second wave, when the volume of cases were much larger, maybe even patients with moderate disease. The symptoms are there for you to see. However, the challenge was triaging these patients on an online consult and trying to bring the right ones into hospital. The fallout of this was that in the second wave, we had patients coming in late. We had patients staying at home, even hiring some oxygen cylinder from a nearby vendor. And hence, we got patients much later on in the disease. From the first. What about healthcare staff? And this brings us to some interesting numbers. We don't have mortality numbers among healthcare staff in this country, be that from the first or from the second wave. However, we do have numbers for doctors, the more sort of elitist class amongst the healthcare professionals, and our numbers in the first and second wave combined, the number of doctors who died was something like 1,000. You compare this with WHO numbers, the World Health Organization describes that about 45,000 odd patients died, 45,000 odd doctors died of COVID-19, and there were about 120,000 healthcare professionals who died during the first and second wave combined. And you understand that the percentage of doctors who died are far smaller as compared to the percentage of cases that we have compared to the global numbers. Hence, we must have done something right in protecting our doctors and hopefully our healthcare personnel. Again, I won't read through these, but you can see what we did were basic things. Plastic screens at registration desks. Developed countries. I show you some screening and isolation facilities. I'll show you a couple of photographs, which is from our premier institute, the All India Institute of Medical Sciences, which is located in our capital, Delhi. And you can see that this compares with any of the state-of-the-art or institutes that you would have anywhere else in the world. You can see this well-spaced out beds. You can see the infrastructure, which is brilliant. And you can see at the intensive care isolation unit at AIIMS. And again, these are pictures which are impressive. However, the number of people who can actually get treated at facilities like this are few and far between. I take you to this triaging center in a healthcare facility, which is a primary healthcare center in Tamil Nadu. And this is what about 70% of the country, 70% of the country saw. So you can see these boundaries which are delineated by means of chalks. These are areas where people would stand while they wait to get into a healthcare facility to get triaged and get treated for their disease. The little room, the gate that you see on there and the gate that you see on there, I hope you can see my cursor, are the gates through which these people enter into the makeshift emergency room at the primary healthcare center. And there, if you had mild to moderate disease, you would go home with some of the drugs that are prescribed in mild to moderate COVID in this country. And if you had severe disease, you would be referred on to a secondary healthcare center, which often would be 10 to 20 kilometers away. And there would be an ambulance which would carry the patients across 10 to 20 kilometers to the secondary healthcare center. So that's most of the country. That's about 70% of what this country did. And you can understand the challenges, but I would argue that we did well. We did better in the second wave as compared to the first, even though the numbers in the second wave, at least on a daily basis, were far greater as compared to what it was in the first wave. You can see there's another slide I've put up about protecting healthcare workers at triage. And it this 1 meter distance between patients was something that was mandated across the board. The use of pulse oximeters, every home in India, or almost most homes in India today, especially in the cities and the suburban areas, would have a pulse oximeter at home. They would have a thermometer at home. These healthcare facilities, one of which I showed you in the previous slide, have a non-contact infrared thermometers, which again produced in large numbers in the country. And then isolation of suspect COVID-19 cases. You remember the primary healthcare center picture that I showed you a little while ago? Masks were provided in the first wave more in the form of a cloth. So a linen cloth which was put across the face. With increasing number of masks produced in the country, we've now gone back to more conventional surgical masks and N95 masks. But just to highlight that this huge population of 130 crores, at least challenge that I'll come back to a little bit later in my talk. So for inpatient care, patients were asked to wear a simple flexible fiber mask, which the hospital or the PHC would supply to these individuals to reduce oxygen aerosol generation. Oximetry would be intermittent, so about 3 times a day is what we could afford in the smaller units that we have across the country. And nebulization was something that got stopped through the pandemic, and it was mainly an inhaler, often with a spacer device, which was used for the prescription and delivery of inhaled drugs. Critical care units, especially in the second wave, was a huge challenge. We had a dearth of critical care beds to a lesser I'll talk about protection of employees again. Things that were done in hospitals were cancellation of elective procedures, a lot of telemedicine, even in rural and suburban areas, limiting point of entry and to manage visitors. There was a lot of security. There were guards around people to lots of individuals to guide people around, and encourage respiratory hygiene using alternatives to face masks, which was something which was used. And then again, ensuring safety to surgeons, safety to interventional bronchoscopists, endoscopists, and so on. So elective surgeries, we said should be postponed. And then where invasive procedures, surgical procedures needed to be done as an emergency, all the procedural precautions that need to be taken were employed throughout the units. So that was the first part of the talk. I'll dwell on in the next 5 minutes, talking a little bit about what's been described as the largest vaccination program in the world. So briefly, that's the Indian vaccine landscape. And you can see that we have either produced vaccines ourselves in this country indigenously, or we have worked with global partners. Pharmaceuticals in this country have worked with global partners in manufacturing vaccines. The Covishield is a result of one such collaboration, where we have collaborated with AstraZeneca, the Serum Institute of India in Pune, and Covishield is the vaccine that's been administered to the most number of people in the country in the first 4 months of vaccination. Covaxin is our indigenous vaccine. Again, large lots in the pipeline, and hopefully the vaccination program will proceed at a greater pace. This looks at vaccine production and capacity handling of, I want you to look at the bottom two, the Oxford AstraZeneca vaccine and Covaxin, which is what's been administered the most in this country and continues to be the commonest vaccines in this country. The mRNA vaccine and the Pfizer vaccine have storage challenges, and we are trying to circumvent these challenges as we go forward. So this is the first phase of vaccination, which is still not ended. We've gone into phase 2, but phase 1 is ongoing. This was the first 30 crore of the 140 crore people in this country, healthcare workers, frontline workers, and senior citizens. Scared for their life, and hence recent surveys show that more than 90% of persons in India are ready to get vaccinated, and that's the least vaccine hesitancy along with China and Vietnam anywhere in the world. I spoke briefly about the cold chain and infrastructure issues, and this is something that involves all sectors and people need to think about, and the government is thinking long and hard about this. I'll skip these slides and I'll go on and finish off by talking about of additional TB deaths would happen over the next 5 years thanks to the COVID-19 pandemic. So the adverse economic impact is something that's going to remain with us, and our per capita GDP investment on health needs to go up significantly. Economic cost of COVID-19 in India projected is the highest in Asia. Poverty rates will increase. Rural migrants are expected to be the worst hit, and a lot of you would have seen the fate of farmers. Forward into this particular way. Thank you very much for listening to us, and it's over to you, Maji.
Thank you, Raja. That was a wonderful presentation and amazing to reflect on India's experience to date. We don't, unfortunately, have syndrome been an issue in India as well?
To a much lesser extent, Maji. To be honest, the vaccine hesitancy was massive going up to sort of end of last year, end of 2020. The second country in trying to get the vaccine. So rather than TTS not being a concern, I think the concern about the disease was far overrode the concern about the adverse effects that the Oxford vaccine might have or does have.
Yeah, no, absolutely. Thank you. I agree. And of course, we've had the opposite problem here. Well, problem, very low disease, and so less sort of perception around